Good afternoon, everyone. Great to see you all. Bringing this to a close today. What a great couple of days. I have been attending these for some time, and we were just talking at the table here that there is quite a buzz in the air. We think there's a lot of momentum right now behind all of the efforts that everyone's undertaking, and I think it's a really exciting time to be engaged in health IT and interoperability in Canada. My name's Larry Sylvester, and I'm a strategist with Oracle Health. And as we come together at the end of this incredible two-day event, I think we can all agree the conversations and the connections and shared insights have truly captured the momentum of digital health transformation in Canada. As we reflect on everything we've heard, it's only fitting that we end by returning to what truly grounds all innovation, and that's trust, transparency, and partnership. At Oracle Health, we are proud to stand alongside Canadian health leaders, providers, and innovators who are reimagining care for the future. Our work across provinces, from supporting integrated care networks to advancing population health management and health systems to deliver better outcomes for every patient, is part of our mission. That said, none of it is possible without trust. And trust from patients that their data will be protected and used ethically. Trust from providers that digital tools will enhance and not hinder their care delivery. And trust from all of us that the innovation can be both powerful and profoundly human. Our closing keynote speaker today embodies that very idea. I had a wonderful conversation with her last night at the reception, and I can say that she's truly passionate about her role and all of the efforts that she puts forward to help patients along their journey. Catherine brings her lived experience as a cancer survivor into spaces where research, strategy, and governance meet. She serves in a variety of capacities in her roles, and I am delighted that she is here to bring some messages to us to really ground the conversations as we've gone from the bleeping computers, where it's all so interesting for us to get really infatuated with the technology and the bits and bytes, so to speak. She's going to galvanize this in the experience of the patient at the front lines in care. And so today, please join me in welcoming a visionary leader, a true advocate for patient partnership, and a guiding voice in shaping the ethical, transparent, and human future of digital health, Ms. Catherine Wilhelmy.
I'll need water, so sorry. Try to find a place. Well, good afternoon. I'm always a nervous reg ball at the beginning, but it'll get going. I'm really happy to be with you today. When I arrived Sunday, sometimes how our body just shuts informations and we just forget about things that we should remember. I arrived and I realized that November 16 was Sunday, and it is the day 7 years ago I was diagnosed with an advanced, aggressive, triple-negative breast cancer. And, over the past 2 days, I've been listening to this conference with that in mind, asking myself, if AI had been available back then, what could it have done for me? Because 7 years ago, at least from where I was standing, AI wasn't really in the discussion. Today, we're applying AI more and more widely in finance, HR, processes. We've talked a lot about getting physicians on board and about how powerful things will get when AI scribes connect to the EMRs. I had an entire slide deck prepared, and I changed it all yesterday. So thank you, Chris and Haley, for your patience, because I just didn't want to talk about impressive potential of technology, how it improves processes and everything. I wanted to talk about the human conditions that determine whether innovations move forward or collapse. And for me, 3 elements are absolutely essentials: trust, transparency, and co-construction. But before we go any further, I'll just go over briefly where I come from. You may hear it in my accent. I come from Sherbrooke, a unique research center where I work, the Centre de Recherche du CHU. In 2017, they became the first research center in Quebec to trust patient partnership deeply enough to make patients true allies in strategic decision-making. It is composed of equal number of researchers, professionals in research, and patients. It was established quietly, without fanfare, and over the years, its members became acquainted to one another. They began to understand each other's realities, bridging the cultural gap between each other. I joined the Patient Partner Strategic Committee in 2019 after my second round of chemotherapy. Bald, vulnerable, I needed a safe space where I would learn about what happened in my body. I needed to find a way to make sense out of that journey I was going through. I found there the safety net that allowed me to learn how to become a partner in research, and later the partnership coordinator of that research center. This group was among the first to document their own development in an institution, and they were also the first to go public about their opinion about AI, data access, and everything, and I'll go over that later on. And now they stand out for their unique way of shaping patient partnership, because the bridges between different realities, the realities of scientific and patients, were bridged really at first. We didn't try to do super wide things. We started by understanding each other's reality to build what was next. I'm also co-lead of Expérience, Quebec's learning community on partnership, which is connected to the Quebec Support Unit to Patient-Oriented Research, commonly known as SPOR units. These units were established in each provinces of Quebec to support the strategy for patient-oriented research that was adopted by CIHR, Institute for Research in Health of Canada. Since 2021, I also served there as co-scientific lead, and that year marked a turning point at the SPOR unit because it evolved towards learning health system. And that's when our patient partners community that was only in research expanded to the whole health system. And the idea was really to connect the health system, with science being made. It's often done everything in silos. We had the idea that we could connect everything. Over time, with that community of patient partner, when we expanded to every patient partner involved in the system, we learned from each other. We learned from what was going on in patient partnership in Quebec. And in 2024, we did a position paper on patient partnership to address what was missing and how we should evolve into that. And that's how 12 of us contributed to system transformation work in Quebec as Santé Québec was created. And it was the first time patient partners were involved at such high level of strategic decision-making in Quebec. Beyond these two central roles, I sit on several committees, often as the first patient partner ever invited. And yes, I'm used to long silences after I make suggestions that fall a bit outside the usual framework. But once the ice is broken, the discussions that occur are so terrific. It's worth doing it. So I don't mind being the extraterrestrial in the room once in a while. I think it's worth it, and it's worth it to open the doors for others. So today, I'll share, did it change? I'm sorry. So I was late. Today, I'll share what I have learned from these different experiences, and I'll go back here and there to share from the perspective I had on November 16, 7 years ago. My goal is simple. I just want to invite you to see digital health not only as data streams or powerful, promising, complex infrastructures, but as stories, decisions, and relationships with people that can help you achieve what you want. I'm talking about the patients. Because everyone that came here since yesterday said it. Canada's undergoing one of the most ambitious digital transformation, and everything is going really, really fast. It's moving faster than our institutions can absorb it. And let me say, probably even faster than the population can follow. But yet, none of the AI scribes or big data will reach its full potential without trust. Trust from physicians, of course, but also trust from the population. Sorry. And trust is not just something nice to have. It's structural. It's a quiet architecture that determines whether innovation will stand or collapse. But in my experience, I also hear often that people resist technology. I don't think so. I've seen innovations fail to be implemented, not because they were poorly designed, but because they failed to engage people. People don't resist technology, they resist opacity. They resist the feeling of being left behind closed doors where people discuss about things that concerns them. You may think AI scribes doesn't concern patients because it's a tool for physicians. You won't know until you have the conversation about it with them. And actually, Dr. Mohamed Al-Arakia told us that he uses it to communicate with his patient, and they even send him back corrections. That's fantastic. If we want digital health to become something people can trust, we need them in your teams building it right now, not tomorrow or when it's ready to stamp-proof it, right now. And that is where patient partnership becomes essential, I think. So today, being a patient that partners in your own health, it's the very first step in patient partnership. It's really like, yesterday Mr. Godbout said something about having rights and responsibilities, and I think it applies in our health. We have rights to get access to the health system, but we have the responsibility of our own health. It's like your car. You have the responsibility to put gas in it. You have the responsibility to take care of it. So your health is the vehicle that'll take you through life. You have to take care of it. It's your responsibility. So being partner in your health, it's paying attention, asking questions, getting help when needed. And at another level, when forging solutions for a health system, people with lived experience will bring insights that no data set will ever provide. They will reveal blind spots, they will surface unmet needs, and they could also even help redefine priorities. At the intersection of all those expertise, experiential knowledge, clinical knowledge, administrative knowledge, scientific knowledge, decision simply becomes just more smart. So let's see where this practice came from. Patient partnership evolved step by step. It started in the 60s with, nothing about us without us. And in the 90s, it shifted from decision made for patients to decision with patients. And there were these models in France. It was the patient resource in UK, the patient expert in US. It was patient-centered care. So that's what happened around the 90s, and in 2010, partnerships started becoming implemented into the policies. In Canada it was, in France it was, and today it's even recognized by World Health Organization. And partnership today is part of education, governance, research, care, as well as prevention. In Quebec, it took off around 2010 with the strategy for patient-oriented research I told you about earlier. And from there, partnership grew into co-developed scientific field with best practices being forged hand in hand with patient and scientific. And now, patient partners are more and more empowered in the system. But while we made significant progress, much of the development happened in silos, which today leads to some confusion. And the most common confusion is between patient advocates and patient partners. Advocates defend rights. Patient partners co-construct within constraint. I often say it this way: advocates identify the issue and they throw the ball forward. Patient partners catch it and work from within the system with stakeholders to find viable solutions for everyone. Both roles are essential, but they're not the same. I really like this image. It proposes that patient partners connect the silos of the system. They're often seeing the whole journey across care, research, governance, and community, and they reflect back to the system where actions match intentions and where they don't. And when it happens, we find solutions together. But is it really consistently applied everywhere in the world when it comes to digital health? Well, not really. Patient partners, when we look at literature, many initiatives claim to involve patients, but very few actually document true partnership. Worldwide, most initiatives rely on surveys, focus groups, which are really useful, but it's not partnership. Partners belong upstream and downstream of data collection. They shape questions, methods, meaning, and interpretation. They do not just provide data, and they co-design the system. But some examples do exist and are worth mentioning. Denmark built its strategy for digital health using 5 key points in their strategy. First one was partnering with the community. Sorry. In Denmark, 4 years of co-creation was not considered as a delay, but as an investment. In Netherlands, patients help determine which outcomes matter in value-based healthcare. They don't arrive just later on in the process. They're at the very beginning. And in Australia, something funny happened, and the country shifted its way of talking about AI. People were scared about AI because of visions like Terminator and stuff like that. And when people were explained that a machine can process thousands of files in minutes, which no human can do, well, then people said, okay, well, it's the human learning from the machine. Why don't you call it that way? And that's what they did. So words count, and words can help shape trust. And as far as AI, digital health, EMR are concerned, like my colleague Raymond Vless, who's in the back, said to me yesterday, we'll have to keep monitoring over time how these topics evolve in the population's mind, because you can get trust, and once you have it, you have to keep it. If you don't address concerns in timely manner, well, the trust can be lost, and it takes quite some time to repair trust. I'm sorry. You may remember I mentioned earlier the group of patient partners from Sherbrooke who were public about their opinion about data access. They made themselves very clear in the memoir they presented at the National Assembly during the legislative reform. You can see it on screen. You can see people aren't afraid of data, they're afraid of silence. And what they ask for is quite simple. They want clarity, predictability, and honesty about real risk and real benefits. Because when you repeatedly say to people, you know, you don't have to agree, you can remove your consent, you can do this and you can do that, well, the natural thing that happens is hesitation. Doubt begins exactly where silence happens. When you think about it, Google, Facebook, LinkedIn, Instagram, they don't constantly remind us what we should be scared of. What they do in many different ways is consistently show us what's in it for us. I'm not saying we should do the same, but surely we can find a space in between so that people understand what's in it for them and what's in it for collectivity. And one more thing that group of patients insisted on, they asked to be at the table when decisions are made about how data will be managed, because understanding fully and contributing, it builds trust. So let's talk about what's in it for patients. I'm going to take you back in time a little bit. On November 16, 17 years ago, I was literally scared to death, and I needed to understand everything because I needed to build a mental movie of what was happening inside of my body and how the Avengers were going to show up and rescue me from the big bad crab. Creating that movie for me was the only way I could keep my mind from spiraling. Every time I searched online, one thing kept coming back. Stage 3B, triple negative breast cancer, 20% chances of being alive 5 years. Let's just say the movies I was trying to write had the flavor of the ending of Thelma and Louise, when what I really needed was the ending of Frozen, where everybody melts down and everything is cool. Years later, I found my own little happy ending. I started working with Thomas Joly-Mislich, an oncology pharmacist, on a platform that documents real-life side effects of oral chemotherapy. At first, we talked mostly about how efficient it was for clinicians, better information, earlier intervention, fewer hospitalizations. But as a patient, what struck me was its potential to reassure. I really felt like a kid in a candy store. This platform was saying, you have a weird rash? Take a picture and send it with the messaging tool. Your experiences this symptom? Here's why. Yes, it's uncomfortable, but it's expected. Here's what you can do by yourself at home. Here's what you have to watch for. And here's if you want to read more. And if you need, you can message your clinical team. On November 30th, 7 years ago, just after my first chemo, I would have needed a tool like that very, very much, because I had never felt in my life not feeling my fingertips or the sole of my foot. I had never felt my heart pounding so fast and not being able to sleep for 3 days. I had never experienced bone pain. I wasn't dying from some weird reaction to chemo, but I didn't know. Had I had access to that platform, I would have learned that numb fingers are expected, and that if it becomes too intense, my oncologist can adjust my medication. I would have learned that bone pain is normal and that it fades before the next treatment. And I would have learned that Decadron is prescribed for 3 days to prevent the kind of side effects you see in movies still. It's basically like drinking gallons of espresso nonstop for 3 days, which explains why you feel hyper with your heart pounding and no sleep. And then maybe I wouldn't have done a full-on hyperactive spring cleaning on day 2. Because day 3, when you stop Decadron, you crash from exhaustion. A platform like the one I was working on with Thomas would have shown me that breast cancer today are really not like what is shown in movies, where you end up crying your life away at the end. It would have realistically helped me know what's normal and what is not, and how to compose with all that. Harjit Kaur talked yesterday about how feeling isolated she's there. How feeling isolated with a disease can be painful. I was far from being in her situation with all the fear having a rare disease, the stigma and everything she had to compose with. But even in the comfort of my normality, I felt totally alone, like dropped in a new foreign country without any translation device. So information sure wouldn't have saved me, but it would have calmed my wariness. And it's nice not to be too worried when you have to recuperate from crab poison. So when Elizabeth Taylor was talking about how data is fragmented in systems and it can't communicate, and when I heard this morning Stuart Gray talking about how physicians and nurses have to take us seriously with the need to get information. By the way, Stuart, I don't know if you are here. Yeah, you have to keep on doing the talks you do with physicians. We need you. We need you to build the bridges between them and us so that they understand why we use AI, so that patients are taught how to use AI, so that AI inventors of a scribe and everything include us into the construction of that so that it can serve us too and the needs we have. So since the last 2 days, my mind goes crazy What if AI Scribe could get even closer to patient? What if it could combine information from both professionals and patients directly within the electronic medical record? What if it could not only document but also reassure patients by guiding patients on how to monitor themselves before seeing the doctor? Sometimes when we go to the doctor, we can't even answer the simplest question like, what brings you here today? So what if patients were correctly supported to take simple actions that would help clinicians better help patients, using actual data reported by patients and captured in their electronic medical record? Things like take your temperature twice a day, without Advil or Tylenol. Write down how often you feel nauseous. Note when you feel pain and how intense it is. Stuff like that. For many patients, that will be super easy. And I know what you're thinking, but what about those for whom it isn't? Well, include them. Include them in building in developing those tools. If you bring them on board, they'll work with you in finding the perfectly adapted solutions. And don't tell me we can't. In the Netherlands, teams have worked with cognitively impaired patients to help them express their wishes for end-of-life care, even decisions about their own funerals. So if we can do that, we can certainly include patients in shaping what AI should do for them. And you know what? We can even go further. Dr. Marie-Pascale Pommet led a study on telehealth, a program for liver transplant patients. It combined digital platforms, connected device, and the coaching by a patient partner, someone who had lived through the transplant experience. Patient partners in that study were involved from the very beginning. They helped design the intervention, identify what matters most, and anticipate barriers that professionals had not seen. This project confirmed something essential. Technology can monitor and measure, but only human beings can build the bridge between innovation and lived experience. And that is where trust takes roots. We know many physicians are concerned about what happens in the black box of AI. At Université Laval, researcher Philippe Després is developing an AI platform to support breast cancer mammogram interpretation. It has enormous potential, but physicians weren't really too thrilled about that. So from the very start, he designed the study so that clinicians train the AI themselves and correct it when needed. AI isn't left on its own, it's shaped by professional expertise. So what if we extended the same principle to patients? Because soon, whether we like it or not, some diagnosis will be made with AI or even partly by AI. So how will patients react to that? What will they need to hear to feel safe and informed and respected? In this project, that's exactly what we're exploring. We'll organize focus groups with women who have had breast cancer and others who haven't, so that when the tool is ready, we'll also be ready to speak with patients and bring them on board, not afterward, at the very beginning. So when I hear that getting physicians on board is essential, I totally agree. But as Marc-Nicolas Kobrinski reminded us yesterday, so is engaging other professionals and also patients. Because if we build the infrastructure only around one or two groups, even with the best intentions, we may end up with something we can't modify, and we won't be able to address the needs that are expressed after. So AI must, of course, be shaped with professionals, but also with others that are concerned, including patients. That's how alignment begins and how trust becomes possible. We've heard how technology can speed up processes in oncology. It's impressive how AI can shorten the distance between a rare diagnosis and the right treatment. I'm going to tell you about Sylvie Breton, a dear friend of mine who had cholangiocarcinoma, a rare cancer where treatment options are scarce and time is precious. Through completely sheer serendipity, she learned why she had responded relatively well to her first-line chemo treatment. A researcher along her path told her that patients who carried IDH1 mutation, like she did, were responding to chemo while others weren't. Her immediate reaction was, why wasn't this tested earlier? Why aren't patients told about that? Why let someone go through treatments that won't work for them? She believed, and she was right, that knowing this earlier has the potential to bring better shared decision-making and to spare suffering, to better respect choices, to support dignity, and to use resources more wisely. This is exactly what Martin Vallière works on, and is using huge mass of secondary health data over a lifetime to identify common patterns in patients with cancer. It could serve to identify, like Sylvie wanted, who will better respond to treatment or how to prevent and diagnose earlier and all sorts of things. I know wherever Sylvie is right now, she must be applauding this project. In that study, patient partners suggested adding a prospective study to analyze how patients respond to information shared about secondary use of their data. When debating on how to inform patients, professionals preferred a really medical beige or pale blue, pale green image with a doctor, and patients wanted something more punchy. The study showed patients overwhelmingly preferred the punchier version. It's a simple example of how patient partners can help teams break out of their old habits and create more human, more effective ways to reach to people. Digital health is not a monolith. Administrators see system constraint and the limits of the resources. Physicians see risks, responsibility. Nurses see the rhythm and the continuity, the coordination. Social workers see the context, the vulnerability. Occupational therapists see daily life and autonomy. Support staff see the hidden choreography needed to keep everything clean, safe, and ready to operate. And patients see real life with a health condition. None of these perspectives are wrong, but no single one is enough. And when these realities remain isolated from each other, well, decisions reflect only part of the truth. That's why we need to build bridges, because connections between all perspectives, they change how choices are made. And this becomes especially clear when we look at the allocation of digital resources. Allocation reveals our values, whose needs shape the agenda, whose priorities prevail, professionals or patients. Are we funding what improves lives or what improves work? And how do we avoid deepening inequities in the system? Because digital health is really about way more than data. It's about people. I'd like to propose an answer to the question asked yesterday. If you build it, will they come? My friend Alvina said to me last night, well, you know, if you build it with them, well, they're already there. We've seen that others succeeded in getting people's trust. They did because they accepted to have the hard conversations and negotiate tensions honestly with those concerned. That's how you get viable solutions that are socially acceptable, ethically grounded, and as future-proof as possible. So having that in mind, co-construction is really no extra work. It is the work. There's no perfect solution, but we have to co-construct the ones that would make sense for all of us. Thank you.